Thank you, Cian Corla, and thank you, Minister, for that. This evening we're talking about emergency departments and bed capacity, and for me, how we can avoid an escalating trolley crisis every year. Before COVID arrived, many of us here right now were debating the trolley crisis. In this room, there were over 100,000 people on trolleys last year, and 13,000 of them on trolleys for more than 24 hours. And we had elderly men and women on trolleys for days on end. I think we were all personally very affected and upset and frustrated by that. And in preparation, Cian Corla, for this evening's session, I just looked back at some of the testimony from that time. We've been in St. Vincent's for 3 days with tea and polite nurses, but 0 doctors. My 86-year-old mum ends up in A&E regularly and has spent days stuck in limbo. My mum is 70 years old. She spent 105 hours on a trolley in Limerick and expressed fears that she would die if a fire started. Our healthcare professionals, as we all know, were overwhelmed, they were burned out, they were exhausted. And however difficult it was going to be to fix that problem, the challenge has become much, much harder now because of COVID-19. We know that there's a huge increase in spending on COVID measures, including PPE, testing and tracing. Waiting lists are up because of the necessary pausing of elective care. Inpatient and day case waiting lists have gone up 30% since March. It's about an extra 20,000 men, women and children waiting. The cancer screening services necessarily had to be closed, but that's, again, putting a huge amount of pressure on the system. And probably the biggest challenge, Cian Corla, is neither of those things. It's the fact that while COVID is here, the infection control measures that the healthcare system needs to use very seriously reduce the capacity we have to treat people, including, critically, the capacity that emergency departments have to care for people. There's estimates that about 20% of the beds in the hospitals are now going to have to remain vacant. Surgeons are estimating in some cases that they'll be able to see about half the number of patients in a given operating theatre session. Diagnostic capacity is way down. Some people are suggesting that more invasive diagnostics like scopes could see reductions in capacity of up to 80%. As the Secretary-General said here at committee a few weeks ago, it's going to cost more and take longer to do less. And that is in a system that was already at breaking point. So what can we do? I think I agree with the Minister. One of the things we've got to do is we've got to hold on to some of the positive changes that happened during COVID-19. Additional hospital beds were opened or reopened. Let's make sure they stay open. And let's accelerate the hospital beds that are in planning or construction. We need to look at opportunities in presentations to emergency departments. So during COVID, presentations went down. Some urgent care went down, which was bad, but some non-urgent care went down as well. And we need to find ways of engaging with those people and getting them to a better place than an emergency department. Now, the Association of Emergency Medicine has pointed out, for example, that some presentations to ED are from GPs who are sending in non-urgent care. They don't want to, but it's the only place they can send patients for things like access to diagnostics and access to care that they should be able to access in the communities. I think a public helpline, which is available to a lot of people who have private health insurance, a public helpline with clinicians on it, I think could be excellent in helping people decide whether or not they need to go themselves or bring somebody into an emergency department. At the same time, obviously, we have to increase resources available to the emergency departments. That includes better staffing ratios for clinicians, better access to diagnostics, and of course, better access to beds. The problem, of course, is that our diagnostic and bed capacity has taken a massive hit, which is going to stay with us for a while because of COVID-19. To put that into context, a 20% reduction in bed capacity, because we've got to keep 20% of the beds open that are normally occupied, would see the inpatient HSE beds fall from about 11,000, which is what we have right now, to less than 9,000. Now, that is a catastrophic loss of hospital beds, which will be seen at the sharp end, which is the emergency departments. So what else can we do? we have to source short-term capacity from outside the public system. We can provide additional funding to the National Treatment Purchase Fund and expand its remit to include things like mental health and diagnostics. We can establish strategic partnerships with the private providers while the COVID infection measures have to be deployed. If we need to access 2,000, 3,000 new beds now, with the best will in the world, that cannot be done simply from within the public system. And these are the kind of measures that we can use in the short term to build capacity. Second, we need to work with clinicians to get as much out of the existing capacity in the HSE as we can. So we've got to look at ways of opening the diagnostic suites longer, opening the operating theatres longer, starting earlier, finishing later, opening at the weekends. We've got to really quickly identify some of the wasteful practices in terms of bed use. So, for example, one of the ways doctors are forced in hospitals to make sure that someone coming through emergency gets an MRI is to keep them in a hospital bed for days, just so they stay on the priority list, rather than sending them home and saying, look, you're on the priority list, come back here in 2 days, we'll get you scanned. We've got to get these things sorted out very, very quickly. Now, obviously, all of this is well and good, but it requires more clinicians, more doctors, more nurses, more midwives, more technicians, more scientists. We need to identify the blockages. The reality is that the number of doctors deregistering has been increasing, the number of vacant posts has been increasing. We need to urgently look at the blockages and sort them out. One thing we can do immediately is look at the clinicians who are going off cycle this summer. My understanding is that we could put job offers in place for them, because a lot of them who might travel abroad obviously won't be able to do so. The third thing we've got to do is we've got to accelerate the parts of Sláinte care specifically around capacity. So the healthcare gap analysis, the workforce planning, getting these new regional organisations in place, getting the delivery plans in place, and accelerating the capital expenditure. Finally, Ken Corla, I'd just like to say that all of this, I imagine every single one of us in this House wants this problem solved, and I agree with the Minister, we are at our best when we work together. Doing this, getting the kind of radical action we need and the kind of radical investment and urgent investment we need, needs a new government. So it is my hope, it is my sincere hope that coming into next week we'll have a new government in place and that government can get stuck into some of these very urgent things. Thank you.